Good afternoon. My name is Cheyandra Brazil, and I will be your presenter today. This presentation is a collaborative effort between myself and Ms. Latanya Lowry as a requirement for course 712, Clinical Prevention and Population Health. Our topic is centered around diabetes management amongst low-income individuals in rural areas as it relates to preventative interventions. In this presentation, we will define diabetes. We will discuss the disparities rural low-income residents experience as it relates to diabetes. We will talk about the diabetic risk factors and complications, the levels of disease prevention, as well as diabetic-specific levels of prevention, our proposed DNP-led initiative, DNP competencies, measures of success, and an overall summary of this presentation. Diabetes is a condition that prevents the body from appropriately utilizing energy from the food consumed. Normal blood sugar levels are less than 100 after fasting for at least 8 hours and less than 140 2 hours after eating. Diabetes can be grouped into three main categories. Type 1 diabetics require insulin injections to control their blood glucose levels. The pancreas makes little or no insulin, so sugar cannot get into the body cells for use as energy. Type 1 can occur at any age, but it occurs more commonly in people under age 30. Type 2 is also known as adult onset diabetes. The pancreas makes insulin, but it either does not produce enough or the insulin does not work properly. It most commonly occurs in individuals over 40 years of age. This form may sometimes be controlled with a combination of weight management and exercise. Treatments may include oral glucose-reducing medications, and that will be either PO or by injections. Gestational diabetes is associated with high blood glucose during pregnancy. Pregnant women have a greater risk of developing gestational diabetes if they are over 35 years of age, overweight, have a family history of diabetes, or a personal history of polycystic ovarian syndrome. Statistics show that diabetes is the seventh leading cause of death in the U.S. It affects millions of people annually, and more alarming, millions of people suffer from undiagnosed diabetes. Diabetes is a disease that affects adults, children, and elderly alike. But with all the given statistics, one thing that stands out is the fact that the prevalence of diabetes is 17% higher in rural areas. General risk factors for diabetes include hyperlipidemia, hypertension, being overweight, age with increased prevalence in adults 45 to 64 years of age, ethnicity with highest prevalence among Native Americans, genetics, history of gestational diabetes, living non-active sedentary lifestyles, and a history of heart disease or stroke. Diabetes can lead to both macrovascular and microvascular complications. Those complications can affect vision, with diabetes being the number one cause of blindness in adults, stroke, neuropathy, nephropathy, with diabetes possibly leading to end-stage renal disease. Some possible disparities that affect low-income individuals in rural communities include lack of social support, issues within the community infrastructure, access to care, and this can include lack of personal and public transportation, education, economic instability. We know many low-income individuals may also not have health insurance, so that can also further limit their access to treatment. There are three different levels of disease prevention. Primary prevention refers to preventing the onset of disease. Secondary prevention relates to attempts to intervene and possibly halt the disease before it fully develops. Tertiary is aimed at improving the quality of life in the presence of disease. The overall goal is to reduce the symptoms. Examples of primary prevention interventions for diabetics would include moderate diet changes, increasing exercise, refraining from leading sedentary lifestyles, and avoiding obesity. Primary prevention would occur during the pre-diabetes phase. Secondary prevention for diabetes would include things to help reduce the progression, such as managing coexisting health conditions. These conditions could include hypertension, high cholesterol. We also want to maintain glycemic control and discontinue unhealthy habits such as smoking. Secondary prevention would occur during the clinical diabetes phase. In the tertiary prevention stage, the patient already has the disease and they may be facing possible complications. In this phase, screening is particularly important. Screening can include those looking to detect any of the following: cardiovascular issues, peripheral vascular problems, neuropathy, nephropathy, and diabetic retinopathy. The DNP-led initiative will focus on taking a stand against diabetes in rural low-income communities. The disciplines involved would include the doctorally prepared healthcare professional. This person will provide oversight, leadership, guidance, and overall structure to help coordinate and manage this diabetic prevention initiative. The nutritionist will act as a consultant, providing advice and guidance with creating individual dietary plans. Many low-income individuals feel that they cannot lead healthy lives because of limited resources, but the nutritionist will help to dispel those myths. The recreation therapist will also act as a consultant, providing guidance and creating individual plans to reduce sedentary lifestyles. The local health department RN and LPN will help manage referrals to local community health departments for initiation of diabetic treatment for their respective patients because the overall goal of this project will focus on prevention. The clergy or chaplain will help to provide spiritual guidance and support as needed. We want to promote holistic ways and feel that spirituality is important in many ways. So you may wonder, why are we so focused on primary prevention? Diabetes is a huge public burden because it can lead to major life-threatening complications. We know that finger sticks and remember regimens may be difficult for some, especially when they may have other existing issues and other competing responsibilities. In rural communities, we know there may not be easy access to health care. Treatment issues may include possible side effects from the medication, such as hypoglycemia. The medications may be costly, especially for those without health insurance. This may cause an additional burden for those with limited income. We propose partnering with local churches and community centers to provide screenings, education, and consultation to rural residents. Our focus will be diabetes, hypertension, high cholesterol. This will be because we know that complications with coexisting conditions can also cause diabetic complications. We want to promote autonomy and motivate the residents to take charge of their health by providing them with glucometers, blood sugar logs, handouts, as well as blood pressure monitors. We want to give them readily access to nutritionists, recreation therapists to help them understand being proactive can lead to lasting health benefits. Because our endeavors will be preventative, we will have the local health department nursing staff volunteer to help manage the referrals made to the health department for individuals who are in need of diabetes management. Through all of the mentioned interventions, the overall goal will be to increase holistic health awareness and promote wellness. We want to decrease the incidence of diabetic progression, increase community engagement, increase the access to screening and referrals because we know that early detection and intervention is key. We want to increase autonomy, personal empowerment, and overall self-awareness. In order for this DNP-led initiative to be successful, the doctorally prepared professional must possess the following competencies. Project management. He or she will be key in planning, implementing, and evaluating. They need keen decision-making abilities and should be both organized and flexible enough to allow change. They need great insight and vision, and also they need to be able to strategize, be creative, and have idealistic ways. As previously stated, they should possess leadership qualities and be able to problem solve and be a source of guidance. Having good interpersonal skills also allows this individual the ability to manage diversity, negotiate, and communicate effectively. Measures of success will include overall impact of the program. They will be measured on a monthly basis and assessed quarterly with overall annual assessment. These measures will include the number of diabetic cases referred to the local health department for treatment and management, the number of hypertension and/or high cholesterol cases referred to health department for management, the number of prediabetes cases managed within the program, and the reported dietary lifestyle modifications of the patients involved. Sometimes in rural communities, residents may feel somewhat overlooked. We want to improve community relations and build community rapport. In an effort to measure this, we want to gauge not only satisfaction from the participants that are directly involved within this program, but also try and elicit feedback from the residents in the rural community as well. We want to look at satisfaction of community volunteers and the length of participant participation. In terms of utilization, we want to look at the number of participants, the number of program staff and volunteers, the number of hours dedicated to the program, and the funding sources versus the expenditures. In conclusion, we know that diabetes is a serious condition that affects millions of individuals. However, it is more prevalent, showing 17% more prevalence in rural communities. The 3 levels of prevention include primary, secondary, and tertiary, with primary being the most important in regards to diabetes. DNP competencies include but are not limited to the ability to make decisions and strategize, project management, interpersonal skills, and leadership skills. The purpose of this DNP-led program will focus on preventative strategies in rural communities with measures of success including utilization, overall program satisfaction, and program impact. Thank you for your attention to this important topic. The final 3 slides will display our utilized references and resources.